tackle it. The patient with or without a previous diagnosis of the heart failure may decompensate with acute heart failure at any time in the post-operative period or perioperative period. And the patient with heart failure who are known are more at increased risk of the major adverse cardiac events with non-cardiac surgery. That is why in revised cardiac index score, a history of heart failure has been associated with an increased risk of major adverse cardiac complications. A lot of cardiac complications may happen following non-cardiac surgery, but we are today more concerned with the congestive heart failure, that is perioperative acute heart failure. The definition is not differed from the conventional definition in the general population, but the time is important here. When the patient developed the episode of the acute heart failure within 1 month after surgery, whether the patient is within hospital or discharged after the hospital needing readmission is known as the postoperative acute heart failure. So it is the timing of the development of the heart failure that is important. And the phenotypically, it is not different from according to the guidelines that it may present with acute decompensated heart failure, which is commonest one, acute pulmonary edema and cardiogenic shock, and lastly isolated right ventricular failure. So how in post-operative period these patients are more prone to develop acute cardiac failure? There are many causes, but the common causes should be remembered first, and we should tackle them very easily. Among them, the post-operative pain, post-operative tachyarrhythmias, and the post-operative anemia that may happen due to bleeding during the operative period. This should be addressed first. Next, perioperative myocardial injury, asymptomatic troponin raised as well as myocardial infarction should be sought and addressed properly. If you look into the incidence and the prevalence, you will see it is not so uncommon. It is 2.5%. And among the patients with chronic heart failure, this is about 49%. And de novo acute perioperative heart failure is more than the patient with chronic heart failure. So many factors can predict the heart failure, patient factor, procedural factor, as well as the surgical factors also determine the outcome, but among which the pre-existing chronic heart failure, pre-existing coronary artery disease, peripheral artery disease, and the nature of the surgery, whether he needs urgent or emergent surgery, is very important factor, predictors for development of the heart failure. What is the impact? That is very important here, because those patients who suffered from a single episode of acute perioperative heart failure, cumulative 1-year mortality rate is significantly high in compared to those patients who have not acute heart failure. On the other hand, needing readmission is more in those groups who have developed acute perioperative heart failure. This is those patients who has chronically heart failure, developed acute heart failure, are more prone to develop cumulative mortality than those patients who have developed de novo acute heart failure. Clinical presentation is as like as that, but acute development of the shortness of the breath with tachycardia, tachypnea, and hypoxemia, these are the important parameter for in a patient with perioperative heart failure. We have to evaluate the patient, and the clinical doubt and high index of clinical suspicion is the main determinant to look into the matter and for diagnosis. And then ECG, very cheaper and available investigation with serial cardiac enzymes with particular attention to troponin I and NT-proBNP. At the same time, chest X-ray, echocardiography, and HRCT to exclude the other differential diagnosis of the acute pulmonary edema or decompensated heart failure is needed sometimes. So NT-proBNP is not only important for diagnosis of the heart failure, at the same time, it helps in prognostication of the patient with suffering from perioperative heart failure. On the other hand, the echocardiography, you will have to see the systolic performance as well as diastolic performance of the heart, as well as other structural condition of the heart. The echocardiographic parameter, among the echocardiographic parameter, LV ejection fraction is a determinant. Those who have got less than 30% ejection fraction has got highest mortality. And this patient, this is the chart shows the 30 days post-operative period follow-up. Those patients who has got less than 30% ejection fraction has got less event-free survival. RV function is an emerging parameter. there is growing evidence that the preoperative reduced right ventricular function is measured by echocardiography is associated with increased rates of perioperative adverse cardiac events. So how to tackle it? We have to diagnose first by certain investigation. We have to assess the precipitating factors. We should come to a diagnosis and etiology. And then we have to treat the etiology. We have to treat the causal factors. That is the vital aspects. At the same time, you have to take the general measures, correct the postoperative pain, electrolyte abnormalities, correction of the anemia. You have to give the respiratory support either by oxygen inhalation, or patient may need invasive or non-invasive ventilatory support. At the same time, you have to optimize the fluid status by IV diuretics, intravenous loop diuretics with or without MRA, and if needed, you have to add the thiazide diuretics. If the patient is fluid depleted, you need to administer the fluid very cautiously, ensure stable heart rate. At the same time, you have to maintain the arterial blood pressure with vasopressors, and if there is evidence of hypoperfusion, you need to add inotropes. And for afterload detection, those patients who are hypertensive or normotensive, you may need to administer intravenous nitroglycerin or nitroprusside. That will produce dramatic improvement of the clinical status of those patients. Sometimes, if all that measures fail, you may need to take the help of the mechanical assistance for the temporary mechanical circulatory support. So, you have to deal in that way. Once the patient is stabilized, you have to plan the patients to treat according to the guideline-directed medical therapy. So, the best way of tackling this acute heart failure is proper preoperative evaluation and planning, and those patients who are suffering from pre-existing heart failure, adequate optimization of the guideline-directed medical therapy. You may need to delay the surgery by 1 to 3 months if the situation allow. So, preoperative clinical optimization, intraoperative very close monitoring and addressing all the problems of preload and afterload and vasodilatation, post-operative vigilance, and lastly, early multidisciplinary involvement in high-risk patient is very essential to overcome the situation, to tackle the situation. The coronary